We are going live in 5 seconds. 5, 4, 3, 2, 1. Sir, we are live now.
Thank you, Maharshi and OrthoTV, and good morning, everyone. Today, we are going to talk about different pathologies around knee joint, which are not that rare, but sometimes they strike us and we might get confused with what to do. We have two excellent speakers from Mumbai, Dr. Chintan Doshi, who talked about proximal femoral fractures, femur shaft fractures a few weeks back, and our own and my dear friend, Dr. Tushar, and he will talk about proximal tibial. His talk in POSICON was very appealing, and so I invited him today to guide all of us today. Dr. Kalpesh Trivedi, who is an arthroscopist from Ahmedabad, he was not keeping well, so he is not joining. And we'll talk about some interesting tibia vara, unilateral tibia vara cases at the end. So I'll invite Dr. Chintan to start his presentation. These all are case-based discussions, so you can raise your hand and inquire. Dr. Godha and Dr. Meet, our current fellows, would moderate this session, and they'll you put your questions in the chat box, and they will inquire with the faculty at the end. I hope you will all enjoy this session. Chintan, go ahead, please.
Can you see the presentation, sir?
Yes.
Yeah, okay. Thank you, Maulin Shah, for inviting me. Hi, I'm Dr. Chintan Doshi, a pediatric orthopedic surgeon from Mumbai. And I'm going to discuss two very unique fractures we don't see very often during our practice. One is tibial tuberosity fractures and the tibial spine fractures. So these two areas are very unique in the proximal tibia, where the ligaments are attached. So tibial tuberosity is the apophysis where patellar ligament is attached, and tibial spine is the anterior prominent part of the intercondylar eminence where the ACL is attached. So both of these injuries are actually avulsion type injuries, where both the ligaments pull on the bony fragment, which is not fused yet, and then it causes the fracture. Typically in tibial tuberosity fractures, let's discuss how it happens, what is the etiology. So these fractures are mostly during adolescence when the physis has started to fuse and the tibial tuberosity physis is still open, and the child is very active in sports. So it happens due to eccentric quadriceps contraction, which happens forcefully during push-off or landing from a jump, and the tibial tubercle growth plate breaks off, which is unfused. So most common is 12 to 16-year-old adolescent. Injuries are basketball the most common because it involves jumping and landing on the feet with eccentric quadriceps contracture. And soccer, football, the other ones, which are contact sports. Adults counterpart of this injury is usually a patellar tendon rupture, and it is not usually the tibial tuberosity avulsion. So because the bone is fused to the metaphysis, then it is a tendon which ruptures. Here the bone avulses from the growth plate. So looking at the classification, which will help us further in the management, Watson-Jones first classified this into 3 types. Type 1 was fracture of the apophysis only. Type 2 was fracture of the apophysis with some involvement of the epiphysis, but the fracture line still not exiting into the joint. Type 3 was where the fracture line exited into the joint and it was displaced. So Ogden then modified this into A and B. He kept the 1, 2, and 3 same as the fracture line not exiting the joint, then exiting the joint in 2 and 3. But A was the simple and minimally displaced fracture. Type B was mainly a comminuted fracture where there were 2 or 3 fragments, and then it was completely displaced. These are 2 modifications which came out after Ogden published his classification, and these were Ogden type 4 and type 5. These were the fractures which were seen again in the adolescent, where the fracture line was going all the way through the tibial tuberosity into the epiphysis and then exiting posteriorly into the metaphysis or posteriorly through the physis.
So Chintan, my question is, do we need MRI to specifically classify these injuries, or we can do it on X-rays only?
So, sir, most of the time X-ray is suggested.
So this happens in adolescence.
Yes. Most of the time, X-ray is suggestive. We see the fracture line. So I'll discuss that in the cases where we
Okay, fine.
have some controversy, but then it can be done on table. But to be on a better side, we can do a CT or a, MRI. So MRI will be better because you can see a associated meniscal injury or other injuries. But it will delineate the fracture line perfectly. So type 4 was going posteriorly, and type 5 was similar to type 4, which was by McCoy and Stanitsky, but the fracture line here also goes to the joint. It's like a Y type. So it through the tibial tuberosity into the joint and then going posteriorly through the posterior metaphysis. So we'll discuss the management based on the clinical cases, not a didactic theory lecture. So this was a comminuted tibial tuberosity fracture in a 14-year-old boy, where he had injury while playing football, and there was an avulsion from the tibial tuberosity side. So I usually do these measurements. So this was most of these cases are from Singapore when I was there for a period of a year, where I saw many tibial tuberosity fractures and almost of all types. So we used to get this measurement so as to get the exact screw length and not having a screw jut out posteriorly or impinge on the soft tissues. So a tibial tuberosity fracture most often and always should be open reduced, not a closed duction, because there is, like how we have for medial malleolus, there is periosteal interposition into the fracture line, and then that can cause delayed union or maybe non-union in the future. So it is always better to open reduce. Reduce it with pointed reduction clamp or with the wires, mosquito forceps. But it is always better to take out that periosteum between the fracture site and the fracture fragment and the parent metaphysis.
So Chintan, can we hyperextend the leg, the tibial part, and see whether it is getting reduced? And if we can reduce it well, can we do percutaneous? Or we have to manipulate the patellar tendon to put this?
Almost always we don't need to manipulate or do see, if we hyperextend, there is a chance it will sit, but again that periosteum or the soft tissue which is interposed will cause hindrance. So you will always see a gap. So when we fix this, there is no gap between the fracture fragment and the metaphysis, and if there is a soft tissue interposition, and it is almost always there, because I might have opened about 6 to 7 of them, and there is always some periosteum going into that area, because see, this is a avulsion type of fracture. So as soon as the bone avulses, the surrounding periosteum just invaginates into that fracture pattern. So it's not a good idea or not a good recommendation to do it as a closed duction and fixation. If you're doing a fixation, open it, remove the interposing periosteum and fix it. Similar to what we do.
I saw your screws in the center. So how you put the what do you do with the patellar tendon? You go through patellar tendon, or what do you do?
Yeah. So patellar tendon is attached to the tibial tuberosity. So attachment of patellar tendon is all the way from the tip of the tibial tuberosity till the time the tuberosity is there till the epiphysis. So most of the attachment we preserve. We don't delineate, or we don't excise and make the fragment visible to us. What we do, the patellar tendon is there. We don't need to do anything. Just make a vertical slit. So that the screw can bury into the tendon and it's not prominent under the skin. So just make a vertical slit and make the screw sit on the bone. And I always try to use a washer whenever it is possible, because screw, these are metaphyseal bone. And if you tighten the screw to get the compression, chances are that the screw head will just go into it and that screw will back out from the posterior side. So a washer is always a good help so that the screw head doesn't, go into the bury into the bone. It is just underneath the patellar tendon. So this is the post-op X-ray of this patient. And we have a 4 months follow where it was completely healed. And then see here, we see this X-ray, screws are very, very prominent. So this is the most common complication or drawback of the surgery. It is always palpable under almost under the subcutaneous tissue, and almost always it is better to do a removal, because it will cause bursa or any other problems in the future.
How long you immobilize, or is it based on X-ray or? How long you have to?
So my immobilization will be based on the classification, how comminuted the fracture fragment is, how displaced it was at the initial stage, and how long we need it to get the callus. In a type 3, I will immobilize it for a longer time because the fracture line was exiting through the joint. So I will immobilize it for about 4 to 6 weeks. In such a case where it is just in the apophysis, I would immobilize it for 3 weeks or maybe maximum 4 weeks, and then start knee ROM. So because this is avulsion, if I start knee ROM on day 2, day 3, again it is only the screw holding the fracture pattern. If there is a pull on the tendon, and these kids are very notorious. First of all, they got an injury because they are very active in sports. They want to go back to sports. So it is always better, if not a cast, at least a long leg knee brace where it can be protected.
No, cast is always good.
Cast, I always prefer a cast. I don't trust the kids, so they always want to go do at least something more than what we always suggest. So yeah, cast is always better. And so we'll go to the next type. So that was type 2B. Now let's discuss this one. A 13-year-old boy heard a pop while playing basketball when he landed on the from a jump. And this looks a comminuted tibial tuberosity fracture, not going into the epiphysis, maybe 1B or 2B. And that was what most of us thought on the poll, which was discussed yesterday. But let's look at the surprise that we're going to get here. So this was the first X-ray before I made any skin incision. I wanted to check, what is the fracture pattern. I went in with the idea it would be type 2B or so. But then once opened, you see my retractors here. It is an open reduction. So once opened, I thought the fragment was moving little more than what usually I see in a tibial tuberosity fracture. So I decided to put a mosquito forceps in, and there the fracture line was already connected into the joint line. It was pretty much mobile. So then what was done? So this was not 2 or 1; it was a type 3 Ogden and comminuted.
So let's redefine the Ogden. Type 1 is kind of undisplaced. Type 2 is only apophysis, and type 3 is apophysis with epiphysis fracture, right?
Type 1 is apophysis. And type 1 can be displaced, but type 1A is minimally displaced and simple single fragment. Type 1B is only epiphysis with comminution or grossly displaced fracture. So that is 1A, 1B. 2A is a fracture line which goes into the epiphysis but does not exit into the joint. So you will see a fragment which is, your anterior proximal tibial physis is also involved, but then it is not quite mobile, and the cartilage and the joint side is still preserved. The bone is still preserved there. So that is 2A, which is minimally displaced. 2B, again, it is comminuted or completely displaced. And 3 is the one which exits into the joint. So that is A and B, again, comminution and simple.
Chintan, can I ask you a question?
Yes, sir.
You may be having the privilege of following up also these patients. So do they give symptoms like Osgood-Schlatter later, means they get anterior tibial tuberosity pain into late adolescence or early adulthood? Are they able to go back to their original sports at the same level?
So they are able to go back to the original sports, that is there. They don't get features of Osgood-Schlatter very often. One, because we are doing a compression here. We are going to put a screw and get a compression, and we want the physis to fuse. Something like SCFE, if you do a in situ pinning, you want that physis to close faster so that it doesn't cause a problem again of avulsion in the future here in tibial tuberosity. So the purpose of, and these are near adolescent, these are almost 13, 14, 15, 16 years old, where, so again, if you do a compression screw in a very young kid, almost less than 10 years, the other complication that we face is recurvatum, because the physis has started fusing early because of a compression screw, and then that will cause recurvatum in the proximal tibia. So these are the common problems: hardware prominence, recurvatum, but not what you think that it would be Osgood-Schlatter or something. And yes, the pain on the tibial tuberosity is there. There is swelling because the screws are poking there. The head is still there under the skin, and it causes bursa. So almost always at 1 year or maybe 10 months or 1 year, once we see that everything is going good and bone has healed well, we remove the screws.
But you can assure them of going back to their sports.
Yes. So about 4 months. Once 1 month of casting till we see healing, and then there is knee range of motion for 3 months. So in 4 months, if the full range is achieved and full power is achieved, then by 4 months they can go back to sports.
Yeah, go ahead.
And most of these cases are from Singapore, so I don't have a very long-term follow-up. The longest I have is about 9 months, where we had removed the screw also. So yeah, but then this is what we follow. At 4 months, we allow them to go back to sports if the strength is good and if the bone healing is good. So coming back to this case where we had a pole, so this turned out to be a Ogden type 3B, and then again the fixation is with CC screws. So now when it is two or three Ogden, we try to fix the epiphysis as well, because the fracture line has gone into the epiphysis. It has gone into the joint. So we want the epiphysis also to fuse along with, or the fracture line and the epiphysis also to fuse in anatomical position. Because if there is any step or anything during the fixation, then it will lead to early arthritis in the future. So we want anatomical reduction and anatomical fixation in this case. So if you see here, I used 2 guide wires. The one in the epiphysis was smaller diameter. The one in the metaphysis was bigger diameter. So what screws we use for tibial tuberosity fracture? If you're putting in the metaphysis, I always prefer to use a thicker screw, which is a 6.5 cc screw. In the epiphysis, we may not have that privilege always. So there may be a thin epiphysis, and of 6.5 may not go all the way and probably may put into the joint or into the posterior physis, which may cause growth arrest. So what we put is a 4 mm, a 4.5, or 4 or a 4.5 mm CC screw, whichever is available. But in this case, so when I put the guide wire, I saw there was enough bone, and I put the screw on the skin and see if it's not going to poke anywhere. So then I put a 6.5 here as well. So that is how we'll fix the epiphysis and the tuberosity onto the metaphysis. So this is a 2 months follow-up of a case which was done. Now, again, this is a bilateral tibial tuberosity fracture. Again, a jump during basketball where the boy landed on both the feet simultaneously, and it caused avulsion of the tibial tuberosity. So we see on the right side is comminuted multiple fragments. Probably it is type 2B because it is going all the way into the epiphysis as well. But on the left side, we see a unique pattern, which we discussed in the classification. The fracture line here is going from the tibial tuberosity. You see the lateral view. It is going all the way, exiting in the posterior metaphysis. So it is type 4 Ogden, which is a modification of the Ogden classification. And there we had, so as Maulin Shah suggested, whether we can see what's happening in extension. So at Singapore, we used to do this in the emergency department of manipulation and reduction, and see what is happening to the fragment, whether it is sitting or not. So we do hyperextension, apply a slab, and then admit the patient. And this is done with a little bit of sedation, because we have pediatric doctors in the emergency department who can give a sedation for a half an hour or so, and then we can do the procedure. Child wakes up with almost no pain because the slab is there. So when we do hyperextension here, so if you see on the right side, the fragment, because of the patellar tendon, it is displaced further than what it was in the before the hyperextension. And on the left side, it's set well, but again, that is unstable because the fracture line is all the way going anterior to posterior. So this was what was decided to fix it on table. Here you see my screw here on the epiphysis screw is thinner than the metaphyseal screw, but it is also going in a different direction. Why? Because the fracture pattern was such. The upper fragment was so oblique that I had to put a screw perpendicular to the fracture line so as to get a compression in a way that it went through the anterior physis. But then that is also important because any which way is almost near fusion. We wanted to get good reduction and good fixation with this fragment. On the other side, I use a reduction clamp, a pointed reduction clamp or a patella clamp to get the fragment reduced in extension, and then put a screw again in this. So these are the long-term follow-ups of these patients, about 6 weeks, and then it went on to both the sides went on to heal. Now, in a bilateral case, I refrained him from 6 months from sports, but then once it heals, we can allow them with good strength. So another case here, this was also a poll option of what is the management for this. And most of us were of the option to do a compression screw. Yes, it is complete. It is quite a bit displaced, and there can be periosteum interposition again here. So in this also, I will do open reduction and not just a closed reduction or a extension casting. So looking at this fracture pattern, on the lateral view, initially it looks, there was some suspicion that it is going posterior. So again, it is not just a simple tibial tuberosity, it is a modification, type 4 Ogden modification, which is the fracture line going all the way from anterior to posterior, exiting into the metaphysis. So again, open reduction was done and screw fixation for the same. And both the screws are 6.5 screws here, and it went on to heal nicely. So this is a 4 months follow-up. And just before starting sports, we want to see that the bone has healed well and there is no more gap at the tibial tuberosity level. So that is our 4 months follow-up of Ogden type 4. So another interesting case, and this I discussed for options in the poll. It looks a nasty proximal tibial fracture, probably metaphyseal, doesn't look like a tibial tuberosity on these x-rays at least. So we decided to get a CT scan done and look at what the pattern is showing. Again, what we discussed, type 4 Ogden type, where the fracture line is in the metaphysis going from tibial tuberosity exiting posteriorly, and the entire epiphysis with the tuberosity and metaphyseal fragment is displaced. So on table, what I had kept everything. I had kept K-wires, I had kept plate, I had kept screws, everything I had kept because I was not sure how it's going to reduce, whether it's going to go into varus or valgus, whether I will need a additional plate fixation. But this is how it reduced. And just with extension and holding the fragment in place, what I decided to do was to put a screw and then check for stability whether to put up additional plate or not. So that metaphyseal line that we see on the AP X-ray is actually that fragment, the fracture line of the posterior cortex, which is the Ogden type 4, the one which is exiting posteriorly. And that is a fragment which is of the part along with the tibial tuberosity, a single fragment. So I decided to do just a screw fixation because it is quite stable. And again, as Maulin sir and we discussed, we're going to put this patient in cast at least till the time we see a good healing and we are sure that it's not going to displace further. I refrained from using a plate here again because there was no varus or valgus deformity, or and it was after putting the screws, it was quite stable. And there was no need to do any additional fixation for this. And for this, I only have a 6 weeks follow-up X-ray with me. Anterior part looks healed very nicely. There is a fracture line which is seen posteriorly as well. So post this, I put him in a long leg knee brace and started gradual knee ROI. And then later on, it went to heal. I don't have a follow-up because by then I had left Singapore. So as we already discussed with Tushar sir here, what are the complications of these? So we have prominent hardware, we have recurvatum because there is early fusion of the anterior physis, and extensor lag because it was a avulsion fracture to begin with. We have immobilized the quadriceps for a very long time, of almost about 4 to 6 weeks. There would be some extensor lag again because the play on the patellar tendon may still be there. So it's better to get rid of it before starting sports. And stiffness if immobilized for a very long time. So take-home messages in tibial tuberosity fracture, it is important to identify the fracture configuration. Displaced fracture will almost need a surgical management, and here it is open reduction, not a simple closed reduction, because there is almost always a periosteum interpose which has to be removed when you pass the screw. Anatomical reduction with screw fixation gives a good long-term result. Only drawback is the prominent hardware, which can be removed once the fracture is healed.
So Chintan, it has been already 20 minutes elapsed, so I would wish you to go rapidly through the tibial spine cases.
Sure. So, I'm sorry, but I think we had discussion in between. So I timed this to go into 12 to 13 minutes, but then it's okay.
No
So
issue.
tibial spine fractures, these are the ones which we are going to discuss here. The one where the ACL is attached. So these are very uncommon 1 in 1 lakh children fractures, not 1 in 1 lakh children, 1 lakh children fractures. Almost these are also seen somewhere near adolescent age group from 8 to 14 years of age. And this is the adult counterpart is the ACL injury here because it is cartilaginous. It may just pull off with the ACL and ACL may not tear, but there is a avulsion fracture. So etiology, the most common is a sudden pull or a sudden break while riding a bicycle, and full knee extension will cause this avulsion. Again, same thing can happen in skiing or any other contact sports. So let's look into the classification, which will help us in the management again. So Mayer's and McIver's classification is a most accepted classification all over the world for tibial spine fractures. It is this into 3 types. Type 1 is undisplaced. Type 2 is anteriorly it is open but the intact posterior hinge. And type 3 is where it is completely displaced and the fragment is completely off the tibial plateau. So imaging the best is a X-ray because you can visualize this, and on a lateral X-ray it is very well visualized. A cartilage fragment may not be visualized, but you may see some ACL laxity. So it is always useful to get an MRI done in these cases. Also because there are associated injuries in most of these cases. So it is usually recommended, like not for tibial tuberosity fractures, but for tibial spine fractures, almost 100%, it is better to do an MRI to not miss out on any other things, and also to look at the fragment. How big is the fragment? Whether it is one single fragment, whether it's comminuted, a screw will help or a suture will help. So all this will be decided on MRI. So again, we decided on, we had a poll on this, and as most of you suggested, yes, the meniscal injury is the most common, almost 54% incidence. So 1 in 2 will almost always have a meniscal injury, some type. May not be a complete, may not even require a repair most of the times, but there may be a tear, there may be extravasation, there may be intermeniscal ligament interposition between the fracture fragments. I'll show an example of these. And sometimes there are associated ligament injuries when the force is into varus or valgus, so there can be collateral ligaments, or sometimes fibers of the ACL are also torn. So type 1 is undisplaced and usually is amenable to casting and extension. Type 2 is we attempt closed action here in casting and extension, but that pull is almost always there and it does not always sit anatomically. There is always an anterior opening. If you see that, it is always better to go on to do arthroscopic fixation or open fixation with a screw or a suture, because that, even if it heals, that will give a laxity to the ACL ligament, and further there will be anterior instability and other issues with the kid. And these patients are very active in sports. Again, it is important that we have a very stable knee because they're going to go back to sports. So type 3 is almost always open reduction and internal fixation, operative reduction and internal fixation. It can be open or arthroscopic, whichever a surgeon is comfortable. Both are accepted. So blocks to reduction, as we already discussed, intermeniscal, transverse intermeniscal ligament and the meniscus are most common. And if you see here, there's a tibial spine, all are marked with arrows. The tibial spine is lifted off anteriorly. The fracture base is that red part that we see on the just below the meniscus, and the meniscus is already interposing between the fragment and the fracture base. So it is always better to visualize this, get the good anatomical reduction, and then fix it. So fixation with open or arthroscopic, whichever surgeon is comfortable with. Screw and suture can be decided depending on the fracture geometry. So let's look into both the options. So open, good is anterior approach, straight midline. You can go parapatellar as well, no problem. Direct visualization of the fragment is very important. Fixation under vision. We saw that intermeniscal ligament always going into the fracture base. So it is very important to fix under vision, get a good anatomical reduction. And disadvantages here, because it's open, we can miss out on fixing the meniscus or anything, which is best done by arthroscopy. So arthroscopy is again the best method, minimally invasive. And if you look into how we're going to fix this, so screw is good and a best option for a single large fragment. It is good to get compression so that there is early healing. Disadvantage of screw is we cannot use it in multiple small fragments because then there is no good hold on all the fragments. And there are with screw there are chances of growth arrest because we may cross the proximal tibial physis. In suture, we use it in comminuted fractures, and I'll show the examples of both. So screw fixation is here. We tried to avoid going through the physis, so we just stopped just short of physis in this case, and it was fixed nicely, went on to heal. In suture, we loop around the ACL, pull all the comminuted fragments onto the tibial plateau, and fix it with a high strength suture onto the metaphysis anteriorly. So this is how suture fixation was done for multiple small fragments. So if you very closely look at the AP X-ray, one of the fragment is still off. There is a little elevated. So that is the problem with screw suture fixation. You may not always get hold of all the fragments onto the bone, and there may be a little bit of irregularity. So and again, it takes long time to heal because there's no good compression how it is with a screw. So screw will heal very fast. So take home message from this tibial spine fractures is it is a unique fracture in children. There are a lot of associated injuries which have to be looked into. There is always an obstacle to reduction which needs to be moved away to fix the fragment. Whether to use a screw or a suture is again a single large fragment. A screw will be a better option. Multiple small fragments, a suture will be amenable to fixation. So thank you very much.
Maulin,
Yes.
I had spoken to my arthroscopist, he had told me he always uses screw fixation and he always advises screw removal.
Right. So that's
So,
right.
yes.
Now, we have a few questions. Yeah, Chintan, you can go ahead on discussion on that part.
No problem. So yes, screw fixation is always better than suture. As I said, suture will take longer time to heal. But if you have multiple small fragments, you may not get hold of everything in the screw. And then it is always, so we may have to shift from screw to suture if at all on table we see that, or sometimes while putting the screw, fragment is so thin, it may shatter. So it is very important to do it very nicely. And yes, like tibial tuberosity, tibial spine fractures also 4 to 5 months. Also, you can remove the screw. If you see you want a longer time, in a year's time, you should remove it. The head is still just under the ACL, the head of the screw for compression. So we want that to come out, the metal to come out from the joint. So it is always better to remove.
So the
though it doesn't cause any
message was to get more aggressive operatively in these fractures. Basically,
yes, both.
The trend was to conserve, not to conserve them.
Both of them.
And how easy or difficult it is to put a screw across if you do open. See, most of us do not have, like we have arthroscopists help with us, but those who do not have arthroscopist colleague or who are not trained, how difficult it is to put a screw across if you do an open thing,
So in arthroscopy also, if you've done it with your arthroscopy friends, we cannot put the screw from the portal that we use for arthroscopy. So the portal is for visualization or for the meniscus repair, but the screw will always require a parapatellar different portal because the trajectory of the screw has to go in that way. So even if you do arthroscopically, we always do a parapatellar mini open so as to get the screw guide wire, the screwdriver, and the screw position in the direction of the fracture geometry.
So to some extent, does it become a blind procedure or we can visualize the fragment completely?
If you're doing a complete open, then you can do like how you open the knee in septic arthritis, you can do a parapatellar, open the knee, look at the fragment. Again, meniscal interposition may be there. So again, when you want to do
remove,
yes, you may
which
have
we
to.
can correct by open procedure also. Okay.
But then open will have more stiffness, will have delayed healing. All those issues will be there with open. Arthroscopy is always the best. So you can mobilize early, there'll be less stiffness. Again, because this is an intra-articular fracture, stiffness, like how there it was prominent hardware, here it is stiffness is the most common enemy, the complication.
Yeah, Goda and Neet, there were some questions. You can moderate those questions.
Yes, sir. We have a question by Gaurav, sir. Can we use headless screws like AccuTrack for tibial tuberosity practice?
So headless screws have been tried, but again, the amount of compression we want. See, we are not exiting from the opposite cortex. So we don't have that hold from the opposite side. So a headless screw may not help us to get the good compression at the fracture side, at the fracture fragment. It has been tried, but then again, gold standard is to use a CC screw.
Okay. And a question by Maulin, sir. What is the incidence of associated knee ligamentous injuries in tuberosity fractures?
So you talked about that in spine fractures about 54%, in tibial
4%.
tuberosity how frequent?
Our fracture line in the tibial. So yes, because of the sports or because of the injury per se, there can be a meniscus. They have reported meniscus injury ACL, but it's not so common. One in a while case would have it. Most of these cases didn't have it. And once they go on to heal. So again, it is not, as you asked me, whether MRI is always needed. Tibial tuberosity is not always needed, because once you have fixed a fracture and there is ongoing medial joint line pain, you can do MRI later on, because meniscus can be fixed later as well. It is not so common.
Right. So let's take other
Tibial
questions.
spine, it is almost 50% of meniscal injury.
So let's take other questions later, Meet, and let Dr. Tushar start his presentation. Chintan, that was an excellent presentation, and all the points were taken well. Let's start with Tushar. All questions will post you separately, and then we'll post the answers in the fellows module.
So, is this seen?
Yes.
And am I heard? Yeah. So, okay, so this is definitely less glamorous, but probably more contextual fracture and a more contextual condition. Okay, so we are talking about the proximal tibial metaphyseal fracture, and specifically we'll talk about the Cozen's phenomenon. So, Chintan did speak about the classification of the tibial tuberosity and the tibial spine fractures, but I feel that it's so tough to remember because you hardly encounter them. So this Scott Mubarak's classification of the entire gamut of proximal tibial fracture is one of the best to remember. So you can have 4 types of injuries: valgus, varus, extension, and flexion avulsion. And as you can see by the illustrations, what each one of them is going to give. And what we are specifically addressing in my talk will be this proximal tibial fracture, which extra-articular metaphyseal fracture, which is almost always a valgus injury. And hence, there is the onset of Cozen's phenomenon, right? And also we will see that the injuries which Chintan spoke about occur in the age group above 10, and specifically these metaphyseal fractures occur in the far younger age group. Hence, again, this talk about Cozen's phenomenon, because there is a problem of developing deformity and the scope of coming out of the deformity. However, I did find some textbook references which insist on much more aggressive maneuvers to get your initial valgus reduced to as much as neutral, maybe little bit of varus, slight overcorrection at the time of primary fracture itself. This was countered by Dr. Sheetal Parekh. After my talk, he says that there is no need to get so aggressive. We may not use any hardware, but for definitely there is a scope for using cast wedging, which is shown in the middle image, to get a proper varus angulation. So these are few examples from textbook images, and you can see this side is the fibula. So this fracture has gone into valgus, and they put a large cast wedge here, and thereby trying to bring it to the near normal levels, and therefore preventing Cozen's phenomenon. And you will notice that the cast is to be done in full extension of the knee, okay, with varus molding and further cast, just a second, and further cast wedging in order to prevent what is called as Cozen's. Now, let us further go ahead and understand whether this Cozen's is a real-time phenomenon or actually it's a myth. So now first I'll discuss two small cases of my own which did not actually go into Cozen's. So I had this patient come at the peak of the pandemic. Okay, so he was a 4-year-old boy. He was extremely anxious with anxious parents. I could not even do an AP X-ray. So I immediately put him into a slab. And those times the trend was to call patients at a very long follow-up. So I called him like after 3 to 4 weeks. And I was aghast when I saw this. Immediately after removing the slab, he had a large medial gap. He also had associated fibular fracture, which was apparent before. And the patient was going into primary valgus. On top of this, I thought that if he gets a Cozen's phenomenon, it would become like a disaster and be very much more difficult to manage. So at this point of time only, I did an intrafocal osteoclasis, fixed it with wires, put him in a cast, and we managed to get a very, very good outcome in this patient. And on a follow-up till date, he's not got a Cozen's phenomenon. So we'll see whether I did the right strategy or I didn't do the right strategy towards the end of my talk. At that time, I was not aware of the correct strategy, I must tell you. Now I got another patient of a 2-year-old girl with an upper tibial metaphyseal fracture. Note that the fracture is complete here. This is not a green stick fracture. Again, we presume it to be valgus, but because there was a posterior angulation, this didn't seem to, so we gave the cast in slight flexion instead of being in extension, but we managed to try to keep giving the varus mold, as you can see, and we got a good varus reduction and alignment. And this patient, came on a longer follow-up for some other purpose, and you can see she did very well with no valgus intent here. So now, is it really, it's a reality or is it a myth? So what are the questions which we ask? So what is Cozen's? When was it first recognized? Why, if at all, does it occur? How early or late can you call it Cozen's? When you get the valgus, when do you actually call it Cozen's? In what percentage of patient population does it occur? So if you have, let's say, 100 patients of proximal tibial metaphyseal fracture, in what percentage will it occur? Which age group is it more common? So if you have 3-year-old versus 8-year-old, when is it more common? Is there a way to prevent it? And can we cast differently in order to get less of this Cozen's phenomenon? Do we ever have to operate a patient who gets Cozen's? If we are operating, how do we operate and when do we operate? For how long do we retain the device? And is such surgery also foolproof, or there are some fallacies of the surgery itself? And if we do not operate, what happens at skeletal maturity? So let's see via the review of literature how we can answer. So another feature that I'll tell you is that you will get roughly about 54 articles when you search for Cozen's, but along with that, you have to put the terminology post-traumatic tibia valga. So everybody does not use the term Cozen's, right? So it's an interesting phenomenon. You can use the term post-traumatic tibia valga whenever you want to search. And if you want to specifically search for surgery for Cozen's, you will find 2 to 3 articles repeatedly coming back, which have been incorporated in this current literature review. So the first article is an original article by Cozen himself. And in this, he found that all the fractures which were initially displaced in the first year itself presented with valgus, and he gave 15 degrees as the significant value. So if you have a femorotibial angle of more than 15 degrees, then you find that parents get concerned. So 15 degrees was the specific value which he said. And he actually at that point of time felt that a long brace with a proper molding would actually help correct the tibia valga. But this is an older article, so they spoke about long brace shoe correction also, which probably the brace which we may have done away with. Now, this is another article by Skack, which is also very prominent in all the, it's very well cited. So he described the upper tibial fractures into 4 types: fissure, buckle, green stick, and complete. And he says that only green stick and some complete fractures will undergo tibia valga. The fissure and buckle fractures never undergo tibia valga. So this is a very important point. So if you ever have just a torus or a small fissure fracture of the upper tibia, they are not going to go into a Cozen's phenomenon. And after his table, he says that only 15% of his green stick and complete fracture had Cozen. So if you have like 100 green stick fractures, only 15 of them will have tibia valgus. But he had two interesting phenomena. He said that even when you leave them for natural remodeling, they remodel in an S-shaped manner. As you can see, so the tibia becomes S-shaped, and almost all of them have a certain tibia lengthening associated with eventual healing, which has been corroborated by all our other papers. So if you ever get a patient of proximal tibial metaphyseal fracture, you may find that there is a certain subtle lengthening of that leg which can persist till skeletal maturity as well, which is shown in one of his textbook images. He gave very interesting take on the theories of why does it occur. So there is lateral growth retardation, there is expansion of soft tissue trapped in the fracture. And this is a very important point which was not mentioned anywhere else, that he feels that there is an inherent valgus in the entire diaphysis of the tibia. And he says that there is a medial periosteal rupture which gives away the medial tether. Okay, and therefore patient goes into a valgus as they grow ahead. And also any patient who has more than 6 to 8 degrees valgus primarily at the time of healing is also very likely to go into Cozen's phenomenon. Remember this. So you should try to bring the initial valgus to less than 6 degrees if you want to prevent a Cozen's phenomenon. This article is also very regularly cited, though they have dealt with only a single case, but this is one of the well illustrated case of using a 8-plate. So 2 years after the trauma and the valgus diagnosis, they used 8-plate, and roughly after 18 months, they got complete correction. Okay. So only the late onset valgus is called as a Cozen's phenomenon, not the primary valgus. They also have given a lot of theories for presence of Cozen's phenomenon. And they say that even in absence of initial valgus angulation, you may have patient progressing to valgus. The main purpose of their article is to say that you should ideally follow all tibial metaphyseal fractures to skeletal maturity to actually comment what is going to happen to them in terms of tibia valgus. Okay. And they find that the increase of valgus happens in the first 6 to 17 months. So this answers another one of our question. Up to when can you get tibia valgus? You can get it up to as late as 17 months. And once you establish that this is Cozen's, then it can improve in the next 2 years. So you have 2 years to wait before you contemplate putting in a 8-plate. Also, they mention the fact that if the patient is coming to you at 8, 9 or 10, which is though rare, they may not remodel, and therefore use of growth modulation in later presenters is more important. So now this is a trick article which they talk about surgical intervention in Cozen's. But actually, they say that none required. So they say half of their patients got Cozen's and all resolved. And they also corroborate the findings that it happens between 8 to 19 months. They have given an additional theory which says that there is a tethering of the iliotibial band which can cause this Cozen's phenomenon. And you see very few patients actually go beyond this 20 degrees mark, which is actually the sort of significant mark of tibia valga where you may have to intervene. So they feel that if you follow for as long as 8 years, which they have done, all of them will resolve. The residual valgus at skeletal maturity is 1.5 degrees, which may not be significant, and the residual lengthening is about 0.6 centimeters. Okay. But they, in this article, they say that there are a lot of emphasis on initial reduction and if necessary, even a mini open reduction or use of hardware to prevent primary tibial valgus. Now, the Peter Stevens articles naturally will talk about 8-plates. So they go in very early, as early as 6 to 8 months following the diagnosis of Cozen's phenomenon. And they talk about overcorrection. So they take about 3, 5, 6 degrees of overcorrection, and that prevents the recurrence of tibia valga according to their paper. And now they have this trend of removing only the metaphyseal screw in order to reapply it if there is a recurrent tibia valga. and their average hardware retention time was 16 months. So that answers our other question. If we use 8 plate, there is bound to be some recurrent tibia valga, and hardware retention is for 16 months. And they talk about regional acceleratory growth phenomenon, which is the theory for the Cozen's phenomenon. They have also published at the time of Staples in 2006. Okay, so Peter Stevens has 2 articles on growth modulation for tibia valga. Now there is this article which is for the first time mentioning that you cast only in extension with varus mold. Some of us tend to cast in about 10-15 degrees of flexion, which should not be done in these primary tibial metaphyseal fractures. So now this paper talks about the tibia valga theories. So when we talk about vascular response and growth stimulation, 8 papers supported this. Soft tissue interposition at fracture site, 5 papers support this. Loss of fracture reduction or initial malreduction of fractures, 4 papers support this. Tethering by fibula or iliotibial band, 4 papers are supporting. And early weight bearing and cast and callus problems, only 2 papers were supporting this theory. And there is now this current 181 patient paper from Harvard, which says that all that is trash. You don't want to follow up all the patients, only those with coexistent fibular fractures or a large metaphyseal gap. These are the only 2 criteria which you should follow, and only these 2 patients will have significant tibia valga, and almost all of them will also not require any operative intervention. So let us see whether we could answer. So we need to make every attempt to minimize the valgus at the time of primary treatment. Regional hypervascularity theory and medial overgrowth is the most favored theory. Cast in extension with the varus mold is the best way to treat them. When you have a green stick fracture of the upper tibia along with a proximal fibular fracture and a large medial gap, they are the ones to go into tibia valga. Follow up for the first 18 months of no matter what in order to rule out Cozen's. If patient is symptomatic and parents are very concerned, then only you offer guided growth modulation. That also after they go into more than 15 to 20 degrees of tibia valga. You can delay your offering of growth modulation to up to 2 to 3 years from the time of index trauma, 2 to 3 years. Hardware retention will be for another 1 year to 1.5 years. And you should err on the side of slight overcorrection. You may remove only the metaphyseal screw and never do an osteotomy to correct the Cozen's. Thanks a lot.
That was a fantastic talk and the great dive into the literature about Cozen, Tushar. And I feel that all the questions were answered. Just a thing about just removing the metaphyseal screw, and if needed, I mean, it takes only 5 minutes to put an 8-plate back. So in our scenario, most of the times parents are not because this means that you are going back to theater if not putting screw in, removing the plate. So we can explain, and the best side would be to overcorrect a bit, so that if at all it gets rebound, there will be neutrally corrected. So that I think let's move on to the next presentation, and if any question we can ask you personally, but this was a wonderful talk and all the fellows should go through it again, and so they would learn all the points about Cozen. Thanks, Tushar. Let me share my screen. Okay. So is my screen visible?
Yeah.
Yes, sir.
Okay. And so I'm going to talk something different than what Tushar talked. We are going to talk about tibia vara, and these are unilateral tibia vara cases. So this 1.5 years old boy presented with unilateral tibia vara. Parents were concerned that child started walking at the age of 1 year. And since then they have observed that this right leg is going in more and more. Now this patient was from a very remote place. in year 2007, I saw this child and I got an X-ray, and this was the X-ray. So I repeatedly inquired with that village family that whether your child sustained a fracture or did he have any trauma, infection. But there was no history of trauma. There was no infection. There was no similar deformity in the family. And for me, it was, it was like I had seen a Blount's case, but there the pathology would be more proximal than distal. Now, when we took the lateral X-ray, there was like a punched out lesion in the proximal medial tibia, and as if there was an osteoblastoma on the lateral film. There is sclerosis which is surrounding this lytic area, but this child was pain-free. There was no pain, so there was no question of any bony lesion malignancy. And if you see the scanogram or standing film of this child, you can see there is tibia vara, and there is punched out lesion of the tibia. And then I did not know what to do. The child was very young, so out of my lack of knowledge, I say that I'll do something once I come back from my fellowship program. And then I got to meet Dr. William Cole, who was one of my mentors there, and at Sikki's, who was originally from Melbourne, and they have described this pathology as focal fibrocartilaginous dysplasia, and that is causing tibia vara. So they found such 3 cases in Melbourne and they reported it. What they found that they have a typical X-ray picture of punched out lesion in the proximal tibia, as you can see here. Usually the pes anserinus inserts on the proximal medial tibia with a small fibrocartilage present there. They opened these lesions and they found that the fibrocartilage analog was very robust, and it is going all the way through the cortex up to the metaphysis, and that was producing probably a tethering effect. And so there was tibia vara with apex at the site of tether. And out of 3 patients, they surgically removed that tethered into, and they did the osteotomy. But the 3rd girl, who was about 2 years of age, was so these are the MRI pictures. This where they have shown this the pes anserinus is included inside the cortex. So the other name of this pathology is fibrous inclusion, or they typically told them based on the histopathology, that is focal fibrocartilaginous dysplasia. So then the 3rd patient of their series, she improved by herself. So 2 patients, they operated for removal of fibrous inclusion, and they did osteotomy. So earlier recommendation with this was to operate, remove the inclusion. But the 3rd child improved spontaneously, and then more and more papers came and discussing about what is the natural history of this focal fibrocartilaginous dysplasia in the young child. Now this series from Europe had 11 patients, and they found spontaneous resolution in most of their patients. The patients in which it did not improve was where the tibiofemoral angle of more than 30 degrees, and they suggested that those patients need intervention. Or the patients who shows progressive deformity, they would need intervention. But the period of waiting for about a year is really important to demarcate that whether it is progressing or regressing. So as I was not aware to what to do for this child, when I came back from my fellowship program, I called that patient back, and the father sent me these pictures and said, my child is all right, and his leg got corrected. So, and I also saw on clinical pictures that his varus on right side, if not, it is partially corrected. And they sent me an X-ray from their place, and which shows that there is gradual remodeling from where we started as the child is growing up. So, and then they never came back to me even after I called them many times. But I presume that the child got corrected by itself. Now, very recently, one of our orthopedic colleagues' niece presented to us with this clinical and radiologic picture. And again, if you look at this tibia very closely, there is a punched out lesion with surrounding sclerosis. And you fear like there is a growth arrest line on the medial side, and the proximal tibial metaphysis decaying like we see in the Blount's disease. But now we know that this is FFCD, and I talked to them about potential of this to gradually corrected with time, although this tibiofemoral angle was more than 20-25 degrees. So this was the X-ray at 1.5 years. And you can see the mechanical axis is passing medial to the joint line. On further follow-up of 4 months, the deformity actually was found to be more progressive. Family was concerned, but I was still with the literature and said, let's wait further. And this is about 8-9 months further. I cannot see how much. Yeah, so this was in September 21, and this, as you can see, there was further, the mechanical axis is on the medial side, and family is now reluctant to wait, and they the deformity was progressing. So they were concerned now that we don't want to wait, you do something, because we have been waiting for almost a year now since we have seen this. And then we went on doing the growth modulation. So that was at the age of 2.1 years, and 4 or 5 months follow-up, you can see that this has started correcting gradually. Now, at 13 months follow-up after index procedure, it has started correcting, but as you can see, the 8 plate has probably exhausted, and the plate is kind of backing off to give more and more correction. So, so this is how it looked at that time, and still the deformity is not corrected. So I convinced them that we have to readjust the plate and the screw. So this was December 22, and further you can see we have replaced the plate and it started correcting. And this is just Meet called this patient yesterday as we had to present today, but you can see this deformity is almost well corrected. And after some time, we will remove it once we achieve some valgus correction. So, yeah, so from here, we could reach here. And in this case, family did not want to wait more because it makes that affected extremity apparently shorter and truly shortened as well. In some patients, we see that there is limb length discrepancy, the affected side is short. And so even though we say we can wait till 30 degrees, even 20 degrees of varus malalignment, child walks with a significant limp, which is very worrisome for the family. Now, this is Taral's case. Again, 2.5-year-old girl, and they kept on waiting, but it didn't correct, and a growth modulation was done. This was at 3 months follow-up. Now, this patient came to me after this surgery done by Taral about a year later. The deformity is not been improving. So this is what I have seen in few of my cases, and as well in Taral's case, that it takes little longer time to correct compared to those metabolic deformities, because when we put an 8 plate, it needs some time for detethering of that fibrous inclusion and restoration of growth from the medial physis. So parent might complain that even after doing surgery, why it is taking long time, but you have to tell them that it might take a little long time, but it gradually gets corrected. So this is at 2.5 years follow-up, and this is 3 years follow-up. Now, there is, you can see there is limb length discrepancy in the tibia, but there are papers which shows that this limb length discrepancy resolves as the child grows. But in 2 of these cases with the Taral and mine, we have seen discrepancy, but families are not coming back, and I hope that this deformity, this discrepancy would resolve. They are still in our follow-up. So if I conclude, about focal fibrocartilaginous defect in tibia. The natural history shows a spontaneous resolution in most of the cases. If there is progressive deformity and tibiofemoral angle is more than 30 degrees, one might need intervention. The earlier recommendation where it was suggested to remove the fibrous inclusion and do osteotomy is no longer existing now. The recent report suggests that growth modulation can correct the deformities, and you keep the implants until it is a bit overcorrected, and then you remove it. The focal fibrocartilaginous dysplasia has been reported in other bones like femur, ulna. Dr. Johari sir has published a recent paper in distal femur. But the treatment principle has been the same. You observe for some time. If it doesn't resolve, then you intervene. So thank you very much for your attention. And it's 2 minutes past 9. And yes, Sujit, this was focal fibrocartilaginous dysplasia. So any question, 1 or 2 questions I can take, or else we will discuss it on fellows group. Do we have any question, Godha or me?
No, sir. We have no questions.
Perfect. So let me stop sharing. So I hope this session would help in your practice. You need to see only one case, and then you will remember for lifetime. I saw a focal fibrocartilaginous dysplasia in Dr. Bill Cole's talk in Sick Kids, and I would never forget in my life. And I hope those who are attending this session, you will also not forget this. So all the talks were great. Chintan, that was a great talk. Tushar, that was fantastic coverage of review of literature, and mine was very simpler talk, but I hope you all will enjoy. Thank you very much. Have a good day. And we'll meet next week with some other interesting pediatric trauma session. Thank you. I'm stopping the meeting now. Thanks, Tushar and Chintan. Bye.
Thank you, sir.